I had one time where Sinersid was not in the panel anymore, but we didn't get the memo, and the QC was out. And I was like, "What's going on?" And it turned out there's no drug, and that was by design. So like that's the one time I can think
Or
of
we've
really,
loaded the wrong disc into like the little stamper. So things like that, it does catch. But very subtle changes. I think it's really challenging with the way we do QC now.
Antimicrobial resistance, or AMR, is one of the greatest threats to modern medicine. Microbiology labs are at the forefront of this issue, detecting AMR in the clinical cultures that we perform through the act of susceptibility testing. As such, ensuring timely and, even more importantly, accurate results is not only integral to the care of the patients we serve, but the data we generate is used to inform governmental, public health, and industry responses to the AMR crisis. So how do we ensure our results are accurate? Most of us monitor the quality of AST through weekly testing of quality control organisms. But is this enough? Might we be missing some testing inaccuracies by relying solely on our QC strains? Are there other approaches to a robust quality system for AST? Let's dig in on today's episode of Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at asm.org/JCM. Editors in Conversation is supported by the American Society for Microbiology, which publishes JCM. If you are a member of ASM, you can get up to 50% off the publication fees when you publish in JCM or any of the ASM journals. Please subscribe to this podcast and share with your friends and colleagues. I'm JCM Editor-in-Chief Romney Humphries, and I'm joined, as always, by my co-host, Ellie Theel. Ellie, hi. I know you're so excited about another AST topic.
Well, you know, Romney, how much I love AST. Yeah. I didn't think I could find another AST-related topic I could possibly love more. I mean, AST QC, what's next?
AST QC, awesome. That is amazing, because I do love AST, is no mystery, but even I don't love AST QC. We're joined today by two fabulous clinical microbiologists, Rebekah Dumm, who is a medical director of bacteriology, AST, and molecular syndromic ID tests at the Barnes-Jewish Hospital, and an assistant professor at Washington University. Rebekah, welcome.
Thanks so much, Romney. I'm really happy to be here.
Awesome. And we're also joined by Laurel Glaser, who is an associate professor and director of the clinical microbiology lab at the Hospital of the University of Pennsylvania. Laurel, welcome to the show.
Thank you for having me. Glad to be here. And glad to hear that Ellie loves AST. I didn't know that about you.
Yeah, no, it's her favorite.
I always think serology.
Did the sarcasm not come through?
Yes. The fun thing is serology is my least favorite topic, and AST is Ellie's. So we're a good pair.
Such a good
complementary.
Yes.
Yes. Can I just say, Rebekah, I love your office.
Oh, thank you.
That is like the perfect office. There's no random papers.
Oh, they're just shoved in front of where the camera can see them, but I do enjoy the light for plants. That's a big favorite of mine.
That's amazing.
I love it. Okay. Continue on to AST.
Okay. All right. Let's focus. Come on. Don't get distracted so easily. So we've invited you both to join the podcast and discuss your paper, which was published in this month's edition of JCM, which was entitled Leveraging Patient Data to Detect Systematic Shifts in Daptomycin Susceptibility Testing with Reduced Prescribing. So thanks for joining us. Maybe we can start by setting the stage, and you guys can tell us a little bit about how AST quality is controlled in most labs.
Sure, I can kick off with that. I think most labs, their sort of routine AST QC process is going to start with testing reference strains. These are strains that are usually publicly available, often ATCC strains, that have a very specific performance for susceptibility ranges to a given antimicrobial drug. And so labs will test them. They'll make sure that they test within range, and if they're acceptable, move forward. Now, how the ranges are established is going to depend a little bit. They'll either be established by the manufacturer if it's a commercial device, or by standards organizations like CLSI or UCAST. And no matter who's setting the standard, the way that it is set is by testing a given bug drug combination across a lot of different settings, multiple labs, multiple potentially countries, to be able to establish that acceptable range and account for the normal variability that you see for that test. Those ranges are fairly static in the sense that they're not updated regularly unless there's been a problem detected. But they're usually used for the end user to basically determine whether or not the drug that is being shipped to the lab is performing as the manufacturer would expect.
Got it. And Rebekah, presumably there's also quality control testing of all of these reagents by the manufacturer as well. So can you talk about what that involves?
Sure. It's certainly not my area of expertise, but my general understanding
not mine
is
either.
That Sure. I'm sure there are others who could speak a lot more informed on that subject. But I do think, generally speaking, the manufacturers are performing a lot more QC on these given reagents than the end user laboratories, right? End user laboratories are really just trying to make sure that the product made it to their lab, made it through the shipping process without any significant damage, and that it's also been shelf stable, right? It hasn't degraded over the time that it's been in the laboratory. Whereas the manufacturers are responsible for QCing their entire manufacturing process. So they include generally a lot more reference strains. Sometimes those are proprietary or publicly available strains, but it's a much more comprehensive process to make sure that the product that they're ultimately releasing to market is of the highest quality. And I should also mention the QC of the reagent is only one small piece of their overall quality management process. And so we as end user laboratories can help them ensure the quality of their materials by sort of feeding back any questions, comments, concerns we might have about the products and how they're performing in our labs.
Yeah. So I mean, I've done a lot of QC for AST and I've reviewed a lot. And it seems to me more often than not, if there's an issue, it's an issue with the QC bug and not an actual issue with the QC or with the test system. Maybe the strain lost a plasmid. Maybe we've not been treating the QC strain in the best way possible. Has that been your experience too? Or can you think of a time where your QC the reagent is degraded?
Yeah, it's not unusual for us to have at least one bug drug combination out several times over the course of a month. And as you said, usually it resolves when we take a new strain out of the freezer and just buy a single repeat. And that is mostly our experience. We do look at the end of the month, and if we see a certain bug drug that's been out multiple times over the course, it always then fixes on repeat, then we try to dig into those a little bit deeper. So that's been one time we've sometimes gotten an early signals if we see multiple QC failures over the course of a whole month. But for the most part, I feel like the QC can help us with some catastrophic failures, like we incorrectly loaded a reagent, we used the wrong media, but it is really not good at picking up subtle changes.
I had one time where Synercid was not in the panel anymore, but we didn't get the memo and the QC was out. And I was like, what's going on? And it turned out there's no drug, and that was by design. So that's the one time I can think
or
of
we've loaded the wrong disc into the little stamper.
Yeah.
Things like that, it does catch. But very subtle changes. I think it's really challenging with the way we do QC now.
How about you, Rebekah? Have you...
Yeah, I'd agree. Overall, it's not a huge value add, generally speaking, or at least we don't catch some of the larger systemic errors that we would hope to catch using our routine QC. I also think it's interesting that you mentioned contamination or losing a plasmid as being a potential shift in the QC from what we're expecting. Just because I think those are sort of uniquely microbiologic challenges. And this is maybe getting a little bit off topic, but we did have some really interesting conversations with our chemistry colleagues as we were putting together this manuscript and just sort of comparing and contrasting some of the ways that we think about QC across laboratory medicine. And I think there are some aspects very much like that are unique to micro and part of the reason why we love the specialty. But there are differences, right? And ways that we have to adapt our QC to be specific to the test that we're running.
So given that it sounds like QC is not the best, given the challenges you guys just described, what other ways and things can the lab do, Laurel, for kind of routine quality assurance practices to make sure everything's on the up and up?
Yeah, I think at the individual patient level, we do have some opportunities. And actually, the CLSIM 100 has a lot of great tables. Like they have a whole table on expected inherent resistances. They have a whole table on unusual resistance. And so we definitely use those. And so if we see something unexpected, that's going to be a flag for us to check. And then in our laboratory, we also have a lot of rules. So if we see a pattern of susceptibility that looks unfamiliar, we don't have a good known mechanism for, that will also flag for our techs to do some checking. So like, for example, if we have like an Enterobacteriales that looks mostly wild type, susceptible, and then has maybe like isolated piptazo resistance, that's a flag. Like we need to check that to make sure that there's not something off on that panel. And we have, I mean, probably way more rules than I could even count. I think the people who come to our AST bench, and Rebekah probably knows this too, are like completely overwhelmed by the number of rules we have. But they're put in place like to kind of try to catch individual issues with testing. And so that's one opportunity we have. We always correlate if we have molecular results with our final phenotypic susceptibility, so that can be helpful. And we review our annual antibiogram every year to see if we see any shifts. And so that doesn't help individual patients because that's only happening once a year. But if we see more than like a couple percentage changes, then we're going to kind of dig into that and find out if it's something technical or if there really has been like a change in the sort of epidemiology of the organisms.
Yeah, absolutely. Rebekah, anything to add there from your side? You guys have many rules.
We do. We have many rules. So we're primarily a distillation lab. So a lot of our rules are also homegrown, meaning that we are coding all of those into the LIS to sort of give more of a guide to our bench technologists, but it's still a lot to keep track of. And as things are shifting and there are a lot of updates, I think AST is one of the areas where you're constantly being fed new information, and it's really hard to keep on top of all of that.
One thing that's occurring to me as you guys are talking about this, do your techs ever have like alert fatigue through all of these rules, and how do you manage that?
I wish I had a good answer, but I think one of the things, we're actually going through a beaker transition right now in less than a month, so wish us luck. But one of the things that we have thought really carefully about as we're moving to the new LIS, and we have the opportunity to essentially rebuild some of our alerts, is making it very clear the ones that have an action required versus those that are informational.
Right.
That's in the hopes of potentially decreasing some of that alert fatigue, but I'm not sure it's possible to eliminate it altogether.
Yeah.
And I think we have another issue where sometimes we use a lot of automated susceptibility testing, and sometimes I do think we see some like lot variation, and we'll see like for a while like a strange patterns emerging, and we'll put in like a rule for checking, and then that checking rule like never goes away. And so it's hard to know, like, especially if you think it's something that was never a problem before, becomes a problem, and then is it persisting as a problem? It's really hard for us to know, like, when is it safe to stop checking? We had this with looking for inducible clindamycin resistance. Actually, like during a teaching session, they did a D-test for fun, and they're like, oh, wow, that didn't match our automated susceptibility. We better start checking those. And it was very hard for us to know, like, during verification, it was fine. And so I think also, you know, once you put a rule in place, it's hard to take it away, even maybe if the problem is not persisting.
I know. And then like 10 years later, you're like, why do we do this? Yeah. So I think, you know, this discussion leads us nicely into the study. So using one of the tools that you've discussed, the annual antibiogram, you both identified a decrease in daptomycin susceptibility rates. So maybe, Rebekah, we can start with you. What did you guys see?
Yeah, so we've had pretty consistently high rates of susceptibility to daptomycin across our gram-positive organisms. And for the purpose of this study, we really focused on enterococci and staphylococci. But up until 2022, our susceptibility rates were well above 90%. And then in compiling our 2023 antibiograms, we saw that drop significantly. So we saw the biggest shift for Enterococcus faecium, and it shifted from 94% in 2022 to 72% in 2023, which was the most dramatic, but all of our gram-positive bugs dropped at least 5%. So that's more than we would expect to see, and certainly not across multiple organisms. And so sort of coincidentally, in terms of the timing, we normally publish our antibiograms or finalize and publish them sort of in March, April. And I think it was in ASM of that year that I was chatting with Laurel about her experience with this particular drug. And fortuitously, she also had seen some issues which made me feel better that I wasn't crazy. It didn't really provide a good solution to the problem, but it at least was a little bit of validation that we weren't alone in it.
And I mean, I think you answered this already, but the reason you didn't, sometimes we see these things come up on our antibiogram. We're like, well, maybe the epidemiology shift, maybe there's this like mysterious MIC creep business happening. So what really made you guys think that it was more than that? And I guess maybe it was just the fact that you were seeing it across a lot of different bugs.
Yeah, I think there were a couple of things that contributed to it. I mean, the first is just that it was such a dramatic shift after such a long period of stability, right? We saw the shift across multiple gram-positive organisms. We saw it across multiple hospitals that we were serving. So it wasn't just, our academic hospital. We also saw it in sort of our community hospitals that we're doing our susceptibility testing for. I think also, and we'll get into this maybe a little bit more, being able to zoom out and look at a larger swath of data helped to sort of see that our QC organism had shifted too. So that pointed towards something technical instead of epidemiologic. But I would say, I think confirming with Laurel that this was shifted across independent institutions. And we did sort of a deep dive in terms of our shared reagents or shared processes. And really the only feature we found in common was the reagent that we were both using in our gradient diffusion strips.
So, kind of thinking about this clinically, during that year, none of the clinical staff reached out to mention, hey, we're seeing more dapto resistance, or they did?
Like nobody reached out to say we think all of our patients are across the board seeing more resistance, but we definitely were getting more individual calls asking what people are surprised, especially for Staph aureus. Like it was very rare for us to have resistant Staph aureus for daptomycin. For ephecium, it was more common. So I definitely remember getting about individual patients over the course of the year in retrospect. But I don't think anybody saw the trend, myself or really any of the clinical. And I think it's because, each clinical person's only seeing a small subset of patients. Right. So I think if anyone's going to catch the trend, it's going to have to be the lab.
Yep. So none of this was really observed by your QC. Is that correct, Rebekah?
Yeah, it's unsettling, but no, unfortunately not.
Yeah, the QC was in for the entire period where we were seeing the elevated MICs.
Yeah.
Scary.
And we in the course of the study, we went back and looked sort of very specifically to see, my worst fear is that we missed something that we should have caught.
Mm-hmm.
And so it went through it with a fine-tooth comb. I think we had something like 10 errors over the course of 3 years of data that we pulled. So it was less than a 0.01% error rate. And I think HUP only had one error, which is actually remarkable in and of itself. So they're doing something right. But it just was a very, it seemed to not show up on any of our sort of routine methods to catch such a subtle shift, right? And if we looked at the difference in the MIC that our QC organism was testing, it was really only a single doubling dilution. So it was subtle enough that we would consider that to be within normal variability for any MIC test. But when you can sort of zoom out and look at the data over a very long period of time, you can appreciate the effect of just a very subtle shift.
It's almost like your Enterococcus faecium, which is not one of the QC strains we use, but sort of was the canary in the coal mine, right? Like it was more affected by this than other species. Yeah. So I mean, I know we've talked kind of broad strokes, but just to get a little bit more fine into the details on what your study entailed. So you both observed this shift over a period, and then it returned back to baseline, right? As you change reagent lots, I guess. Maybe Laurel, you can tell us a bit about that.
Yeah, well, I mean, the very first thing we did after we sort of had this discussion about the change in our daptomycin antibiograms is we compared our lot numbers across both of the hospitals. And actually we had, Rebekah, I don't know if we had any. We had very few shared lots, if any.
I don't think we had any.
So we knew very quickly it wasn't like a lot specific issue. And that was really when working with our colleagues who do more chemistry and informatics was helpful because they were able to graph for us across time the MICs of our organisms, Eufysium and staph, and Euphycalis, the MICs from our QC data. And it's when we did that and looked over many years that we were able to really see those shifts that were happening. And they were time delimited, and we could see sort of 3 time periods, like a pre, an affected period, and a post period, and it went across multiple lots in the manufacturing process.
Interesting. And Rebekah, did you guys reach out to the vendor? Like, did they have anything to say about this?
Yeah, so I think that part's really interesting. We kept trying to report it. My supervisor was like, what do you want me to say on this? They're asking about QC failing. And I was like, well, QC never failed, but we still need to report it. And so we actually had to get quite creative in terms of getting a hold of someone. And we essentially had to show them, we had to have our full data set, right? We had to show them the problem visually because there was really no good way of describing it. We couldn't say like, oh yeah, a single doubling dilution and all of a sudden our patients are testing resistant. They were going to say your QC was in range. We don't know what to tell you. So we did learn through that conversation that there was sort of a time period of the manufacturer that they had suspected there was an issue with their instrumentation that they had seen in other drugs and had pulled those drugs from the market. But this was one, again, so subtle that it had escaped, I think, their attention. I also think one of the things, coming back to this being not necessarily a lot specific issue or maybe potentially lots within a given time frame, one of the things that made me feel better about it was that we were able to sort of empirically confirm it. So we went back and retested some of the isolates that had been non-susceptible during that affected period with more contemporary e-test lots, and essentially saw that they dropped multiple doubling dilutions. So on average, it's about 2 doubling dilutions, and almost all of them, almost 80% of them, were recategorized as susceptible from non-susceptible the way they originally tested. So I think there were a couple of independent sources of sort of data and confirmation that helped us pinpoint the issue, but it was very challenging to communicate those results to the manufacturer without sort of giving them the whole scope of what we knew.
Right.
That's challenging. That is challenging.
Definitely.
So,
go ahead, Ellie.
Nope, go for it.
Well, I was going to say, and I guess from a manufacturer perspective too, it's such a big deal to remove things from the market, for them to, is there really an issue? And it can be hard for them as well. So yeah, it's challenging all around.
Yeah.
Definitely.
So Laurel, you mentioned that, during that affected time frame, you guys got a few more calls from the clinical practice, but did you see like a measurable change in daptomycin prescribing over that period? Or was this did it go, unnoticed or unaffected from a prescribing?
That's a good question. From the HUP side, we weren't able to really get good data on actual prescribing. So I can really only speak from sort of what my experience was, but we didn't have like questions from stewardship about changing, say, like different algorithms for treatment. And I think for the most part, people were still empirically shooting with daptomycin if that was going to be their drug of choice until they would see the final susceptibility. But Rebekah was able to actually pull some good data. So maybe I'll ask her to talk a little bit about her experience.
Rebekah, what did you guys find?
Yeah, so we were able to pull data from the medication administration record, essentially showing that, especially for Eufysium, right, where we saw that most dramatic shift, that our prescribing changed from a median of about 4 days of Dapto days of prescribing to 0 during the affected period. So we did see a decrease, and that's a median, right? It's averaged across a lot of isolates. But I also think that data is interesting because we did see that dramatic shift on our antibiogram, right? That was the conversation during our antibiogram distribution that year, was what's going on with daptomycin. So I do think we saw people pull back even before we sort of had resolved the issue. And luckily, the publishing of our antibiogram sort of coincided with us switching lots that largely resolved the issue.
Right.
So we had a little bit of time to breathe and sort of troubleshoot. But I do think some of that caution around daptomycin persisted. So even after our susceptibility rates shifted back up, we still saw that our prescribing of daptomycin remained sort of depressed relative to our baseline.
Wow. That's really interesting, right? It just goes to show more than just at the individual patient level, the impact of this type of event, but, at a systems level, how people respond to this type of event. Yeah, really interesting.
Yeah, definitely.
So, Laurel, you guys, one thing I thought was really interesting, I think at your site you confirmed daptomycin resistance by alternative methods.
We do. So for us, and this might be a reason why we didn't see as dramatic a shift in our antibiogram. So we had daptomycin resistance as like a director review. So if the techs had a daptomycin resistance, then the director on call would take a look at it. And we don't have like a specific algorithm, but basically we look at things like what's the specimen source? Is like a blood culture versus like the third organism in a toe? Is it how close was it to the break point? Is it Staph aureus, which is really rare, versus Ephesium, where we're more common? We look at the patient factors, like had they been on a lot of daptomycin, and we kind of make a call and if we were going to check it. And some of this came into play because we had been using broth microdilution for a long time, and for some technical reasons, we changed to e-test. And often when we have a new drug, a new method, like we'll have a director review for unusual susceptibility for a while, just as we kind of get our feet wet with it. And so we were sort of in that process at the time. But I think it does show, like, even though we were reviewing all the cases, like it didn't seem like we had an excessive number to the point we thought there was really a problem. Right. But clearly the ones that we probably should have checked that we didn't. So I think if you're looking at something that you've got it all figured out. So I think it is good to like remind ourselves, like there's a limit to like what you can figure out on like an individual patient basis. And so even with that, we certainly still saw the shifts. And I don't think we really came away feeling that over the course of the year that we'd had like a huge change in our susceptibility.
Yeah. Well, especially if it's Enterococcus faecium, right? Because they're kind of intrinsically resistant to daptomycin.
Right. It's not unusual to see resistance. Like, a lot of patients that have VREs have had a ton of antibiotics, so they often fit the profile where you'd be like, that makes sense. Yeah, really interesting.
So one thing you guys mentioned in the paper was looking at MIC shifts as a way to look for dapto AST issues. But if I remember correctly, over the last 25 minutes, you guys mentioned that MIC testing is notoriously variable. So how do you differentiate normal variation from something that's a bit more substantial? And I will point out that this also has relevance to serology as well when we're looking at our IFA QC, for example. So teach me. Rebekah, let's start with you.
I wish I could. No, I think balancing the sensitivity for detecting when there's a problem with the specificity that we don't want to be, concerned about every result that we release. That balance is different for every single test. MIC testing does inherently have a certain amount of variability that we expect. But I think that's why I like this idea of incorporating the patient results as sort of a clinical signal when something is going wrong with the test. And I don't think we have a good precedent for how to do that in AST necessarily, aside from sort of an annual antibiogram. I do think based on some of this work, we're hoping to move forward with some modeling work to help provide some of those insights to some of those subtle signals. As Laurel was talking about, a human eye might not catch some of these trends either in the short or the long term. And so potentially leaning on some more modeling tools to detect some of these things that are more subtle shifts.
Yeah. Yeah. I mean, I think our chemistry colleagues do this really well, right? I think even Ellie in serology, you guys do this better than us, but like trending, the index values and all that jazz.
We do a lot of trending. Yep.
Yeah.
That's true.
Yeah, for sure. So, I mean, the thing I think was so cool about this study, and the reason I wanted to invite you both on, is I think it speaks to both of you seeing something and then being really curious about it. Okay, like, what is this? Is it more than just a blip in our antibiogram or whatever? So you kind of recognized it after the fact. But I wonder how you guys think about this prospectively, and maybe it is that monitoring and modeling of MICs going forward. But like you say, Rebekah, it's hard to know when you pull the trigger on, oh, wait, there's a problem here.
Yeah, I think this is one of the hardest things that now that we've sort of gone through this work and we're like, wow, that hurts that we had all this QC done. And like after all of that, we still didn't really detect a problem until like really years later. And I do think it's a big challenge because I can tell you just getting the patient data from our LIS did require me to work with our informatics specialist. It wasn't something that I could pull or our manager could pull. And so I do think we need to create the tools that are going to allow to do this, because as Rebekah said, we're going to need some statistical control over what does it really mean to have something have changed? How much data do you need? I just don't think we know for AST how to do that. And so I think that's going to be work for our community to do. And then we're going to have to make it accessible to everyone by kind of starting to build it into our LIS types of systems. So I think it's going to be a long challenge.
I foresee WestGuard rules.
Ellie, I love the WestGuard.
Yes, apply it. Find a way to apply it.
Right. And I think that's what we need to do, to understand when you're statistically out of control versus just seeing some random variation that you can accept.
That's right.
And try to balance those two factors.
Although I will add that we do review Levy Jennings for our AST data, which I know is unusual, but it is produced by our LIS in a format that is absolutely awful. It spans across 60 pages horizontally. You're flipping through them, and it's again, it wasn't on a time frame that would have been relevant necessarily for this sort of subtle shift. Maybe we would have noticed it in the first 3 months, but if we didn't have a significant enough clinical signal in those first 3 months, we wouldn't necessarily have known. So I know there's a lot of other proponents of a rolling antibiogram where you're looking at sort of a shorter period of time. But then the downside of that is you don't have the statistical power to necessarily make some of those conclusions that we're used to making with the annual antibiogram, right? Is a 2% shift, is that significant? Or what's our threshold for that? So I just think there a lot more is unknown than known in this space, but I totally agree with Laurel that developing some of these tools is probably the first step, just to get access to the data in a way that we can sort of manipulate.
And the other thing I was always taught was no susceptibility test is perfect. If you have a question, call the lab. So I think it's also about us making it known to our clinical colleagues, nothing's perfect. If something isn't adding up for you, if a patient isn't recovering in the way that you expect, let us know. And there are options to retest or to take a look at things. So I think that's important too, no matter how perfect our QC is.
Yeah. And I think that how you all looked at this across multiple organisms is important, because the thing we're always battling is there's the test system, but the bugs are constantly changing, right? And so you may see some legitimate early trends for shifts in susceptibility that have nothing to do with your reagent, but you've actually identified something that may be important, but we don't, generally on my antibiograms, unless it's a pretty big shift, I'm not worrying about it too much, because these things bounce around. Yeah, very cool. So, I think you guys both know, but I know many people listening may not know, but CLSI recently shifted from their traditional quality control recommendations, which is that weekly QC that we all do, to something that's much more risk-based. In other words, using your test system, all of the factors that you employ in your lab routinely to inform how often doing QC makes sense. So after everything we've talked about today, I'm curious if either of you are looking towards changing your QC frequency or pulling in other information from your testing into your quality control. Maybe Laurel, let's start with you and get your thoughts.
I really like the idea of a risk-based assessment, because I think one of the problems with this is there are so many bug drug combinations. You're looking at, hundreds of individual tests, and I think that can be overwhelming. So I feel like our approach, as we're kind of rethinking the QC, is starting with what are the bugs and drugs that we know are problematic? We sort of know daptomycin and ephesium, that's been challenging. The breakpoints have changed. There's no susceptible category anymore. So I think that's a good one and we know it's a drug that people use a lot. And so I think focusing on things like that is a good place to start, and thinking about the site of infection, focusing on what can you do best for bloodstream infections, what can you do best for sterile body sites, and maybe worry less about urinary tract infections, where we know whatever you treat the patient with, more they may get better even if it's test resistant. And so I do think a lot of it is really thinking about where you're going to make the highest impacts, not worrying so much about drugs that are not commonly used.
Yeah.
So I think that's kind of where we're starting from. And I think we're willing to do kind of more background testing in those kinds of more like sort of confirmatory testing in those with those strategies. And so that's sort of how we've been starting to think about it. We haven't made any changes yet. But in terms of like getting patient data, for instance, like I would definitely start with and like working with stewardship to say like, what's the drugs we're using the most commonly? Where do we see the most problems?
Yeah.
And kind of starting there, because you can't do everything all at once.
No. Rebekah, how about you guys? What are you guys?
Yeah, so it was really interesting. A lot of those conversations were happening sort of around the time that we were grappling with what do we do and how to respond, knowing that we have this issue. One of the things that I think I'm struggling with is part of the reason why we were able to sort of pinpoint this issue, and specifically to the very specific time frame that we did, is because we hadn't done any sort of reduced frequency AST testing for Dapto. So we had a lot of data to look at and to correlate. So and there are pros and cons, right? Both directions. We obviously don't want the lab to be doing testing for the, once in a decade experience that we had with this particular drug, but how to balance having enough data that you can monitor trends over time with not putting the burden on laboratories to do all of this AST. So we have actually IQCP'd a couple of our e-tests since going live with, since the updated guidance. Daptomycin is not one of them based on our experience. You'll not be surprised to hear. But so we're thinking about how we can implement it. Again, based on a risk assessment, right, for our individual lab and our experiences.
Yeah, absolutely. And I guess the idea is, if you're not focused on, doing routine QC for things that aren't used very often, and you're focusing on implementing these types of things, maybe at the end of the day, we just have a better system overall. But gosh, making that change is hard. People love their weekly QC. So yeah, it's going to take a minute to think about this differently.
As I think about this, like the lab, you've recommended ways that the labs can maybe look at this differently, but I would hope that the manufacturers take something away from this as well. Or is there anything that you would suggest that the manufacturer could have done to catch this issue or prevent it from happening again?
That's a tough one. I think it was subtle enough that I'm not surprised it was missed.
Mm-hmm.
I do wish that maybe there had been a little bit more communication once it had been realized, because I know we were not the only two labs that experienced this. But that's, again, it's retrospective. So I don't have a good answer for prospectively. Maybe someone who knows more on the topic of manufacturer QC can educate me.
But I think Rebekah led a good example of not giving up when you've because often it's true when you call and your QC, or sometimes they want you to send the isolate, and when they test it, it's fine. And maybe sometimes even when you retest it, it turns out okay, but you're seeing a persistent problem. Like, it is important to keep, because when we found the right people, then they were really interested in talking to us and helping us. But I think you have to kind of get past that initial phone call. And so just to be persistent so you can really work with them. And then it gives them a chance to alert other labs. I mean, in this case, I think the issue was over, so there wasn't really too much they could do. But if you're kind of in the heart of it, it's good to keep pushing, because you can help your colleagues that way.
And I wonder, one thing that we've started to do more in infectious diseases testing is multi-institution kind of surveillance. I'm thinking of like the BioFire panels where, everybody's uploading all their data. I wonder if there's a world where having that macro level of susceptibility trends could help manufacturers identify these types of issues much earlier, insofar as, like they'll be, the larger your N, the easier it is to see a subtle shift, right? So maybe something like that could be something that they think about too.
Yeah, I did a lot more reading on regional antibiograms prompted by this particular study. So I think there's a lot of really interesting ways if we could all put our data together.
Yeah, very cool. Cool. Well, any last thoughts, both of you, from how we think about susceptibility testing QC, or words of wisdom for everyone who's now anxious about their QC results not helping them?
I just have a question. Ellie, do you like AST QC more or less than when we started?
I plead the fifth. You guys have made me more nervous about it, that's for sure. No, this has been, as with all of the AST podcasts, I always learn something new. So this has been great.
Well, thank you both so much for joining us. And for those of you listening, if you're interested in this topic, definitely check out their paper. Take a look at some of those CLSI risk-based approaches to QC changes, because that's a nice tool. And if you were not interested in AST, the good news for you is Ellie's picking the topic next month. And I can almost guarantee that it will not be a susceptibility testing topic. So anyways, thank you guys so much for joining us. And for those of you listening, if you've enjoyed it, please subscribe to the podcast, and even better, share it with your friends and colleagues. And if you're interested in the paper that we discussed today, and I can't imagine how anybody wouldn't be, the link is available in the show notes and at asm.org/EIC. So thanks again, guys.
Thank you.
Thank you.